Hi Medicos, this is Dr. Natisha Arora. I am a consultant radiologist based from India, and today we are going to discuss about the interstitial lung diseases. It is a very important topic and it is highly tested on your radiology residency examinations. It is also very commonly tested in many competitive examination in form of MCQs. So I am going to cover the basics, the classification, and then we will cover each and every ILD and all the must know points which you should know before any medical examination. So let's start. So, before we start discussing about the various interstitial lung diseases, it is very important that you should know common terminologies, okay, so that it becomes easy for you to understand that what particular findings are present in which ILD, okay. So, I have just shortlisted 4 basic points, so, okay. So, first of all, let us see honeycombing. So, in honeycombing, you can see that there are these cystic changes. These are the subpleural cystic changes. But to classify as honeycombing, it is important that there is a layer of the cyst present. Okay, so at least 3 layers should be present in order to classify as honeycombing. So for the honeycombing, these are the subpleural cystic changes present in a layer. Okay, so that will give you an honeycombing appearance. The second is the reticular opacities. So this is usually present in the early stage of the disease. This is nothing but it is fibrosis. Okay, so when the fibrosis start, it will usually start as intralobular interstitial thickening. You can see that there are these thin lines in the subpleural location. ये आपका pleura है. This is the pleura. So in subpleural location, when there will be intralobular interstitial thickening, this thin lines you will see. These are nothing but your reticular opacities. Okay, on X-ray we call these as reticulations. These fine lines. Okay, so this is basically an early stage of fibrosis, whereas honeycombing is actually late stage of the fibrosis. Okay, so that is basic about honeycombing and reticular opacities. What about traction bronchiectasis? Okay, to classify as this traction bronchiectasis, you can see that there are bronchi that are dilated just next to the pulmonary vessels. Okay, so you can easily differentiate it from a cyst. There will be dilatation of these bronchi just next to the pulmonary vessels. Okay, and this also will be seen within 2 centimeter of the pleura. Okay, usually bronchi will never be seen within 2 centimeter of the pleura, but if you are able to see this dilated bronchi within 2 centimeter of the pleura, then we will classify it as traction bronchiectasis. Okay, so that is all about your basic morphology: honeycombing, reticular opacities, and traction bronchiectasis. Okay, this one you know, everyone should be knowing. This is a ground glass opacity. Okay, if you are able to see the vessels through any opacity, then it is ground glass opacity. If you are not able to see this vessels and it is relatively more dense, more whiter, that will be consolidation. So this is a ground glass opacity. So I hope this basic fundas are clear in your mind before we start discussing about ILDs. Okay. So now let's move towards the classification of interstitial lung diseases. Basically, when we talk about ILDs, it can be either idiopathic or it can be secondary to some another cause. When we talk about idiopathic, it is a major chunk of ILDs which is commonly tested. Okay, so if you see at this particular chart, I'm talking about idiopathic. We do not know any cause. Okay, there is a patient who has come, there is fibrosis, you have detected an ILD, you do not know a cause. Okay, then it can be any of these following findings. Okay, so when we talk about the major findings, the major ones, they will be chronic fibrosing. Okay, which are chronically present in a fibrosing state. So it is mainly idiopathic pulmonary fibrosis, that is the most common idiopathic interstitial lung disease, IPF. Okay, or it can be a non-specific interstitial pneumonia, which we call as NSIP. Okay, so that is basically chronic fibrosing. Okay, when we talk about smoking related, okay, the patient has a history of smoking, still it will be classified as idiopathic interstitial pneumonia only. Okay, so when we talk about if the patient is having a smoking history and there are some characteristic imaging features, then it will be either a desquamative interstitial pneumonia, DSIP, or either it is a respiratory bronchiolitis, ILD. Okay, and if I talk about acute and subacute, the patient has come with a very rapid onset of an interstitial lung disease. We do not know a cause. Either it can be a cryptogenic organizing pneumonia or either it can be an acute interstitial pneumonia. Okay, we will be studying about the imaging features of each and every ILD so that we can know that what particular ILD is present just on the basis of imaging features and a bit of history. Okay, so that is about your idiopathic interstitial pneumonias. Under this category only we will have idiopathic pleuroparenchymal fibroelastosis and idiopathic lymphocytic interstitial pneumonias as well. Okay, this is also called as the PPFE, which is pulmonary fibroelastosis. What happens in this pleuroparenchymal fibroelastosis? There is usually an apical pleural thickening, which is completely idiopathic. We do not know, there is no history of tuberculosis, there is no history of radiation, which is commonly seen with pleural thickening. Okay, if we do not know, if there is no such inciting factor, there is no etiology known, and still you see this fibrosis, fibroelastosis, it becomes PPFE. Okay, and what about LIP? LIP is another characteristic thing. These are very rare ILDs, but again these are under the category of idiopathic ILDs. Okay, we will discuss about the imaging features. Now, interstitial lung diseases can also occur secondary to connective tissue disorders. Okay, like for an example, scleroderma, Sjogren disease, and it can also occur in occupational causes like asbestosis, berylliosis, and it can be secondary to drug side effects like for an example, bleomycin or methotrexate. Okay, so these are some drug side effects and they can also lead to fibrosing pattern. Okay, now what about granulomatous? We have already discussed sarcoidosis in detail. You can check out my video on sarcoidosis where we have covered everything in just 10 MCQs. And I have covered each and everything about sarcoidosis and what you need to know about as a disease in radiology. Then hypersensitivity pneumonitis, that is usually secondary to inhalation of the bird dust. Okay, that is commonly seen. Okay, and that is a completely different entity which we will discuss in detail. We'll cover a bit of this in this lecture also, but we will also have a separate lecture on hypersensitivity pneumonitis. It is again very important. And what about infections? Again, infections chronically, like for an example tuberculosis, that will also lead to fibrosis. Okay, so this is basically a broad classification of interstitial lung diseases, and we are basically going to emphasize on the idiopathic interstitial lung diseases in this particular lecture. So after we have seen the classification of ILD, I am sure that you have got an idea that interstitial lung diseases which leads to pulmonary fibrosis, it can be idiopathic, we do not know the cause of it, or it can be secondary to smoking, autoimmune etiology, hypersensitivity pneumonitis, medication induced or occupation related. Okay, so autoimmune related means it can be Sjogren disease, or it can be scleroderma, or it can be polymyositis. All these secondary causes, connective tissue disorders, they can also lead to an interstitial lung diseases. We will understand about the various patterns of it. Okay, so let's move towards our first ILD, very classical. You can see that here what we are seeing over here, you can see that there are these reticular opacities. Okay, so reticular opacities are present. Another thing you can see over here is that there is also traction bronchiectasis, right? Traction bronchiectasis, you can see that just adjacent to the pulmonary vessel, if you see that the bronchus is dilated within the 2 cm of the pleura, then we will also classify this as the traction bronchiectasis. Okay, so you can see that reticular opacities are present, bronchiectasis is present, means there is some sort of fibrosis going on. If you see this image over here, there is also an added honeycombing. There is also added honeycombing over here. Okay, so if you see the classification of this particular disease, I am sure that by now you have got an idea. We are talking about usual interstitial pneumonia. Okay, so UIP is basically the pattern. Okay, when we are talking about an interstitial lung diseases, you should also know that there is something called as the pattern which are seen on the HRCT images. So here this is usual interstitial pneumonia pattern, where you will see reticular opacities, bronchiectasis plus some honeycombing is present. So that is UIP pattern. In which particular scenario you will see the UIP? You will see UIP in idiopathic pulmonary fibrosis. Most commonly you will see this UIP pattern in an IPF, that is an idiopathic pulmonary fibrosis. Okay, so that is the basic funda, but it does not end over here. You need to know a very important chart. I have taken this chart from Radiology Assistant, and if you know that UIP can be either a definitive UIP pattern, or it can be a probable UIP, or it can be an indeterminate, or it can be an alternative diagnosis. So when we talk about definitive UIP, all the three features which I have discussed over here, reticular opacities, traction bronchiectasis and honeycombing, will be present in a case of definitive UIP. Okay, so if you see that there is a subpleural and basal predominant fibrosis, that is as those reticular opacities we were talking about. If there is honeycombing is also present and there are traction bronchiectasis, this is a case of definitive UIP. One thing to know over here is that in definitive UIP there will be an apico-basal gradient. What do you mean by that? In the apices you will see that there is relatively sparing, but if you move towards the lung bases you will see that the disease is going to increase. There will be more fibrosis in the lower lung lobes. So that is basically about your definitive UIP. If I talk about probable UIP, means fibrosis is there, reticular opacities are there, traction bronchiectasis is there, but the honeycombing is absent. Okay, so if only this particular image is given to you, this will be a case of probable UIP. Okay, but if you see this particular case in which fibrotic opacities plus honeycombing plus traction bronchiectasis, everything is being shown, then that becomes a case of definitive UIP. Okay, so that is a definite UIP. Okay, what about indeterminate UIP? Indeterminate UIP is something which is between definitive and probable UIP pattern, means that there is some subpleural and basal dominant fibrosis is present. Okay, honeycombing is usually absent when we talk about indeterminate UIP, and these reticular opacities or fibrosis, that is also very, very subtle. It may be in the very early stage, and you can say that maybe the traction bronchiectasis is also not present. So somewhere in between definitive and probable, that will become a case of indeterminate UIP. Basically you are not able to understand from the pattern yet that this can be a case of UIP. That becomes your indeterminate UIP pattern. Okay, now in all these three things, definitive, probable and indeterminate, a common thing is absence of the CT features inconsistent with UIP. That is your alternative diagnosis. If any of the things from alternative diagnosis is present, then that will put our case against an UIP pattern. So what are the cases? What are the points which you need to know which will make it an alternative diagnosis? So if you are able to see that there are large amount of ground glass opacities, okay, or if there will be many nodules, or you are able to see consolidation, or you are able to see mosaic attenuation. Mosaic attenuation, you will have areas of ground glass opacities plus there will be some patchy areas of air trapping also. And if you will be seeing some cysts, if all these things are present, then it is absolutely against UIP pattern. Okay, we have to think about something else. We have to think about different patterns. We have to think other than the IPF pattern. So if you see this particular image, this is also a case of UIP. Now you can say that what type of UIP pattern is there. You can see that there is honeycombing. Okay, there are cysts that are present in 3 layers. There will be also some traction bronchiectasis over here, and there are also some reticular opacities present. So all the 3 things are present. This is definitive UIP pattern. Another important thing to note, you can see that there is a basal predominance. Apices are relatively spared. There is an apico-basal gradient. So definitely this is a case of a definitive UIP pattern. Okay, and if the cause is not known, if the etiology is not known, we will classify it as a idiopathic pulmonary fibrosis. See why it is important to know that UIP pattern jab hota hai and the cause is not known. We know that this is an IPF. In such cases we do not have to do a lung biopsy to make a confirmatory diagnosis. Okay, if all these hints are present and etiology is not known, in that case we can basically skip an invasive procedure of lung biopsy and manage the patient according to the IPF only. Okay, so this is about your UIP pattern. Let's move to an important point about the connective tissue disease UIP. So you know now that we have discussed the UIP pattern. If the cause is not known, it is an IPF. But suppose you know the cause. Suppose the patient has a connective tissue disorder. Okay, like for an example, patient has Sjogren disease or patient has a scleroderma. Okay, and if you see this particular UIP pattern, then this becomes a connective tissue disease UIP pattern. Then you will not say it as an IPF. IPF is solely when we do not know the cause, it is idiopathic. But if there is an underlying factor to it, if there is an autoimmune disease present, okay, then that becomes a particular case of connective tissue disorder UIP. If you do not know that a patient has a connective tissue disorder and you are still, patient is under a laboratory workup, there are some signs which are present on an HRCT image. Okay, so this is something which you should know. Can you see that there is a straight edge over here? Okay, so all the fibrosis findings are present, but it is absolutely in a straight edge. This is called as a straight edge sign. Okay, so if such a finding you are seeing in a UIP pattern, okay, you can see a clear demarcation between a normal lung parenchyma and a fibrotic lung, that becomes your straight edge sign, and this will give you an hint that yes, it can be a possibility of a connective tissue disease UIP, and you should do a workup accordingly. Maybe patient may have a scleroderma, or patient may have rheumatoid arthritis, we do not know, but we will do a workup. These are subtle hints which you can get on an UIP pattern HRCT image. Okay, if you see that honeycombing is present anteriorly, okay, anteriorly also, or it is present in all the four corners and not just limited to the basal areas, this is also called as anterior upper lobe sign, and this is also called as an interior upper lobe sign. And if you are able to see it in all the four corners, okay, extensive honeycombing that is present in all the four corners, this is basically giving you an idea that yes, extensive fibrosis is present, there can be an underlying connective tissue disorder present, like for an example the connective tissue disorders like scleroderma and Sjogren disease, which we have already discussed. Okay, so that is all about these particular signs which you should know, which are basically giving you a hint that it can be other than IPF, like a connective tissue disease UIP. Now let us move towards our next pattern, okay, or the next diagnosis. Okay, so you can see in this case there is lot of ground glassing. Okay, ground glass opacities are present, plus there is some traction bronchiectasis also present. Okay, so ground glass opacities plus traction bronchiectasis, what are we dealing with? This is very characteristically seen with NSIP pattern. Okay, now another thing to note over here, can you see how homogeneous this is? How homogeneous this is almost present on bilateral aspect, and you can see that hardly any particular lung parenchyma is spared over here. So this is what is a homogeneous distribution. Contrast to UIP is usually heterogeneous. That means that there will be some areas of lung parenchyma that will be completely spared, and there will be very patchy involvement. Some parts are spared, some part will be heavily involved. So usually UIP is more heterogeneous, whereas NSIP is usually homogeneous. So if you are seeing ground glass opacities with secondary changes of the fibrosis like traction bronchiectasis in this case, then we are basically dealing with the case of NSIP. Now NSIP, again, they can be two types, cellular component and it can be a fibrotic component. When we talk about cellular component, it is usually more of ground glass opacities, and important thing to know about is it is still reversible. Okay, once you start the treatment, maybe you give some steroids to this patient, it is, or you give immunosuppressants, it is still reversible. That is about a cellular NSIP, whereas a fibrotic NSIP pattern will be having more fibrosis, there will be more reticular opacities and there will be more traction bronchiectasis. Usually honeycombing is not seen in the case of NSIP, and that is why we classify NSIP as an alternative diagnosis to an UIP pattern. Okay, so if it progresses to more of fibrosis, then it becomes and enters into a stage of irreversibility. But overall NSIP has got a little better prognosis than UIP. Okay, now one important entity which I would like to discuss with you is CPFE. So what does CPFE stands for? It stands for combined pulmonary fibrosis and emphysema. Okay, so if you are able to see this image, you can see that there is honeycombing, there is traction bronchiectasis, there is reticular opacity. So definitely this is the case of UIP, a definitive UIP pattern. But also you can see that there is emphysema. You can see this patchy air lucencies over here. You know, as a radiologist, this is definitely emphysema. Okay, it's like pan-acinar and centrilobular emphysematous changes present in the upper lung lobes. So it is combined fibrosis plus there is emphysema. Okay, so usually what happens is that the patient is usually a smoker, they have this history of COPD, and because of this emphysema is already present. But if the patient also has a idiopathic pulmonary fibrosis, in that particular conditions it becomes a combination of both the findings, and so this fancy term has come, which is combined pulmonary fibrosis and emphysema. It is something which is, I feel, is very important, and it can be tested on your radiology residency examinations. Okay, so this is all about CPFE. Okay, now if you see this particular image, you know that here there are ground glass opacities. Okay, I have not shown you much of fibrosis over here, and it is just ground glass opacities. But important thing to note over here, this is a spotter classical image. You can see that there is a dilated esophagus. Where do you see this dilated esophagus? You see it in a case of scleroderma. So they will usually give you a clinical history and a clinical hint of scleroderma, and then they will give you this image with a dilated esophagus. Now you are able to see that there is some ground glass opacities present, there is some interstitial septal thickening present over here. This is basically, and how bilaterally symmetrical and homogeneous it is. So we are basically dealing with NSIP pattern. Okay, so this is scleroderma. Okay, and this is basically a connective tissue disorder, NSIP. Again, NSIP can be idiopathic, but it can be also seen in connective tissue disorders. And here when you are giving a dilated esophagus, you should think nothing else. They are basically testing you for scleroderma. Okay, so that is about your NSIP pattern. So now let us move towards our smoking related interstitial lung diseases. Okay, so if you see, this is an upper lobe image, and you can see that there are multiple small nodules. Okay, there are multiple small nodules present over here. So these are nothing but, you can see that these are centrilobular ground glass nodules. Okay, so if you are able to see this centrilobular ground glass nodules in a patient of smoking, and it is usually having an upper lobe predilection, okay, we are classically talking about respiratory bronchiolitis, smoking related respiratory bronchiolitis. Again, this is very commonly seen in smokers. We see these cases a lot, and the common differential to this is an hypersensitivity pneumonitis case. So an acute HP will also present with such nodules, but they are not just limited to upper lobes. They will be seen usually scattered in the entire lung parenchyma, and then they will usually have some sort of history of, say, asthma or atopy also. And here in smoking, they will give you a classical history that the patient is a long-term smoker, and these nodules with ground glass and these ground glass nodules present in the upper lung lobe is more classically with smoking is respiratory bronchiolitis. Again, this is very much treatable. It is reversible also. So it is important to know that yet the fibrosis has not taken place, and this is reversible. Okay, when we talk about this particular image, again they will give you a history of smoking. Okay, they will not just give you some simple just image like a ground glass opacity, because there is a huge differential to ground glass opacities. But if they give you a history of smoking, okay, and if they are basically showing you these ground glass opacities, now this will be having a predilection for the lower lung lobes. So that is basically a case of desquamative interstitial pneumonia. Okay, now this DSIP pattern, again, it is also reversible, but it has got a relatively poor prognosis as compared to respiratory bronchiolitis. Okay, another thing to know about the smoking related ILDs, as you can also see some cystic changes, and you can also see some changes of emphysema in these particular patients. Okay, so that is basically about your smoking related ILDs. Okay, so this is what I was talking about when we talk about acute hypersensitivity pneumonitis. Again, you can see these particular small centrilobular nodules. They can be also present, so you can get confused with respiratory bronchiolitis, but you will usually have a particular history given to you of smoking in RB, whereas in acute HP you will have a history of either some atopy, or there will be some particular history of being a farmer, or there is some dust, inorganic dust exposure present. Okay, so now let's move towards our next image, and that is a triple density sign. Okay, so if you are able to see an HRCT image with both the normal lung parenchyma with areas of ground glass opacities and with areas of air trapping, we are classically talking about your chronic HP, okay, or subacute HP, and it is usually called as your mosaic attenuation. But if you are able to see even the areas of air trapping, then it becomes on the expiratory images. Okay, then we are basically talking about your chronic HP pattern, or we are talking about your triple density sign, or it was formerly also called as the head cheese sign, okay, because of its resemblance to a head cheese. Okay, you can just Google the images of head cheese. How does it look? Okay, I don't find any resemblance, but yes, it was earlier called as the head cheese sign. Okay, so this is also a very classical spotter image, and they will usually give you this history of the patient being a farmer or being exposed to some dust materials, okay, or basically some having a history of long-term exposure to some birds. So basically they will give you this history of pollen exposure, okay, and this is a classical case of chronic HP with triple density sign. Okay, Now let's move towards our next interstitial lung disease. So here we are going to discuss about some acute presentations. Okay, we are talking about some acute presentations of the interstitial lung diseases, like for an example, maybe 3 to 4 days of respiratory difficulty, some breathlessness, or maybe some cough. So some history that is basically 3 to 4 days, and when they will give you some pattern like this. Okay, we do not know so these are all actually diagnosis of exclusion. Okay, you have ruled out that there is no bacterial or viral etiology, or there is no connective tissue disorder or something like that. If you are not knowing the history and it is something which is idiopathic, then we will start thinking about these patterns. Okay, but there are some hints which you can see on the HRCT image. You can see that there is some consolidation. Where is this present? This is in the subpleural location. Okay, another thing over here is that this is peribronchovascular distribution. Okay, so if the consolidation is present in the subpleural pattern or in the peribronchovascular distribution, having an acute history, all the causes have been ruled out, we are basically starting thinking about organizing pneumonias. If we do not know the cause, it becomes cryptogenic organizing pneumonias. Another classical thing over here is the et al. Sign. So this was a very classical case which I had seen during my residency. Okay, so you can see that there is some ground glass opacity present inside, and then there is this beautiful rim of consolidation. This is basically your et al. Sign. Okay, or it is also called as the reverse halo sign. Okay, so in the halo sign, it is usually consolidation with surrounding ground glass opacities, which are usually seen in the cases of hemorrhages or in CMV infections, or it is seen during aspergillosis. I have covered that also in detail in my aspergillosis lecture. Do check that out. So this is basically an et al. Sign or reverse halo sign, and this can be seen with cryptogenic organizing pneumonias. Okay, so this was a case of COVID 19, and in COVID also et al. And reverse halo signs were being reported, but if you do not know the cause and everything else has been ruled out, then start thinking about cryptogenic organizing pneumonias. But the classical thing is subpleural peribronchovascular consolidations, and either they will have this et al. Or reverse halo sign. This is not seen in all the cases, but yes, it has been reported. So that is about COP. Again, it is very much manageable. The treatment is basically corticosteroids. Okay. So now let's move towards our next image. You can see that there is an extensive ground glass opacities involving almost the complete lung parenchyma with interstitial septal thickening. At first glance, obviously you will think that it can be a case of ARDS, acute respiratory distress syndrome, and the patient usually with such you will be given a history of an acute presentation, maybe 3 to 4 days of respiratory breathlessness. But if there is an underlying cause to it, say for an example, there is a drug exposure or drug toxicity, or there is some pancreatitis, or there is some sepsis, or maybe say burns, then we are thinking about ARDS. But again, if you do not know the cause, patient has come to you with 3 to 4 days of viral like prodrome, some fever, some breathlessness, and another thing you are noting on the HRCT is such massive involvement of the lungs without any known cause. It's a diagnosis of exclusion. This is called as an acute interstitial pneumonia. It is also called as a Heman-Rich syndrome. Okay, so this has got a very, very poor prognosis, and usually the patients, they have a very high morbidity and mortality with these cases. Okay, so this is about your acute interstitial pneumonia or the Heman-Rich syndrome. If you don't know the cause, it is not ARDS, it is a AIP pattern. Okay. So let us now discuss about brief differences between the acute interstitial pneumonia and ARDS. I think it should be very clear in your mind that we are not dealing with ARDS. Okay, so when we talk about a idiopathic cause, anything which is idiopathic, we do not know the cause, it's diagnosis of exclusion, this becomes your Heman-Rich syndrome or the acute interstitial pneumonia. Whereas ARDS will be usually having a diffuse damage due to an identifiable cause. See, the pathology is completely same. If you see the histology, there is a diffuse alveolar damage in both the cases with some hyaline membranes. Okay, histology is same, but you need to understand what is the cause behind it. Okay, if you do not know the cause, it becomes AIP. So if you see the onset, it is usually having an acute onset with viral like prodrome. This is also acute within 1 week of the insult. Now the another patient profile which you can get is that this will be usually seen in middle-aged patients who are previously absolutely healthy. Okay, whereas in ARDS, it is usually seen in critically ill patient, like example I said, sepsis or pancreatitis or burns with predisposing risk factor. Okay, symptoms are also more or less same. Okay, and the HRCT images are also same. There will be diffuse involvement with ground glass opacities with consolidations that will be present. So the key differential point is that this is a diagnosis of exclusion. Okay, so prognosis is also very, very poor. It has got a very high mortality. Okay, so that is about your AIP. Okay. So now let's move towards our next image. You can see that there are multiple cysts present over here. Okay, so when we talk about cystic lung diseases, again it is a very, very vast topic, and it is a separate topic which has to be covered in a separate lecture for its differential diagnosis, and it is again very commonly tested, and hopefully I'll cover it in my upcoming lecture series. But this is when we are talking about interstitial lung diseases, we do not know the cause, again a diagnosis of exclusion. Okay, it is idiopathic, and you are seeing this very, very well defined cysts in bilateral lung parenchyma. We are basically talking about LIP, or the lymphocytic interstitial pneumonia. It is basically deposition of the lymphocytes along the interstitial lines. So that happens with the LIP pattern, and this will lead to the formation of this cyst. Now another thing to remember about LIP is that it is very commonly associated with Sjogren disease. Okay, so it can be seen with the connective tissue disorder. See again, LIP, it can be idiopathic or it can be secondary to connective tissue diseases. So it is very, very commonly associated with Sjogren disease. Patient has Sjogren disease, you are seeing multiple cysts, it is a case of LIP. It is also being shown that it has got a good association with HIV. Okay, so it is seen even in the HIV patients. And if you are given a history that there is a child, okay, who has an LIP, okay, then just rule out that that child doesn't have HIV. So it is commonly associated in pediatric HIV as well. So this is very commonly tested, especially for those who want to give FRCR. This is very commonly tested on the FRCR examinations as well. Okay, so that is about LIP pattern. Okay. So now moving towards the end of lecture, I would just like to briefly concise connective tissue disorders and what patterns are commonly associated with them. So either it can be an idiopathic interstitial pneumonia, or either it can be secondary to a CTD, but you need to know that what patterns are common. So just if you know that rheumatoid arthritis, the pattern commonly seen is UIP pattern. Okay, if I talk about scleroderma, I have also shown you an image of scleroderma in which there was an NSIP, bilateral homogeneous ground glass opacities with the dilated esophagus, that is scleroderma. So you need to understand that in scleroderma, UIP can also be there, organizing pneumonias can also be there, NSIP can also be there, but the most commonly pattern which is found is NSIP, whereas in RA the most common pattern is UIP. They will give you a history that there is a middle-aged woman and who is having bilateral symmetrical involvement of proximal joints with erosion. Okay, so there is, you will basically make a diagnosis of an RA, and then they will give you a lung image with definitive UIP pattern or maybe a probable UIP pattern. Then start thinking about a connective tissue disease UIP. And also what another thing about the CTD UIP is there, that there will be exuberant honeycombing usually present. There can be four corner signs, or there is an anterior upper lobe sign, okay, or there can be a straight edge sign. So that I think is now clear to you. If I talk about polymyositis and dermatomyositis, in these patterns you will either have an NSIP pattern or either an organizing pneumonia pattern. Okay, whereas if I talk about the multiple connective tissue disorder, in that again NSIP is common. Okay, one important thing to note over here is that the Sjogren disease में LIP is very, very common. So the ones which I have marked in red, I think that you should know very, very well. Okay, SLE is something which is like a mix. Any particular thing can be present, but you will have a very characteristic history with SLE like photosensitivity or a malar rash or a multisystemic involvement. Okay, and then any of these patterns can be asked to you. But commonly tested ones are basically Sjogren disease with an LIP pattern or scleroderma with an NSIP with a dilated esophagus pattern. Okay, so that is all about this connective tissue disorders. Now just a little bit of your testing time. I have involved some 3 to 4 MCQs, not more, but it will give you a clear idea and whether you have understood anything from this lecture. Okay, so which of the following HRCT findings is most specific for UIP? Whether it is ground glass opacities, or it is honeycombing with basal and peripheral predominance, or it is traction bronchiectasis, or it is reticular opacities. So very, very specific, okay, which makes it from probable to a definitive UIP. What is that? It is a case of honeycombing. Okay, so if honeycombing is present, then we say that it is a definitive UIP pattern. So the answer over here is B. Okay, next is a patient with subacute cough and fever shows peripheral and peribronchovascular consolidations with reverse halo sign or atoll sign on HRCT, which statement is true. Okay, so first make a diagnosis in your mind. Patient is having relatively acute symptoms like cough and fever, and there is an atoll sign present. So what we are talking about? We are talking about an organizing pneumonia. We are talking about organizing pneumonias. Okay, now I'm not basically concerned about the cause over here. If we do not know the cause, it is cryptogenic, but if we know the cause, and it is an organizing pneumonia secondary to a cause, like for an example a virus or maybe a drug exposure, something like that. So what are they trying to ask? Which statement is true? Most likely UIP. Of course it is not the answer. Associated with asbestos exposure? No, there is no such history of asbestosis with organizing pneumonias. They usually give you a history of either pleural plaques or mesothelioma if they want to test you for asbestos exposure. Has poor prognosis similar to IPF? No. We have talked about organizing pneumonias. They have a good prognosis. Usually it is reversible with steroids. So the answer over here is that it is reversible with steroids. Okay, so they are basically testing you to make a diagnosis and what is the treatment of that particular diagnosis, right? Next is lymphoid interstitial pneumonia is most strongly associated with. Okay, so this also I have covered very nicely. It is mainly associated with Sjogren's and with HIV infection, and also it is commonly associated with pediatric HIV infection. So what we are discussing, what is the answer over here? It is very simple. It is HIV infection. Okay, now LIP carries an increased risk of transformation into. Okay, so this is something which I have not covered, but it is very logical to think, even if you know the name, even if you know the full form, it is lymphocytic interstitial pneumonia. So there is an increased chance of what? Whether it is small cell carcinoma or a non-Hodgkin lymphoma or an adenocarcinoma or a squamous cell carcinoma. So it is basically your non-Hodgkin's lymphoma. Okay. Now, if they basically ask you that what particular malignancy is common in UIP pattern, okay, so it is most common is adenocarcinoma only. Okay, in general also adenocarcinoma is more common, and with ILDs also adenocarcinoma of the lung is more common. But if they give you a characteristic history of LIP, maybe they are they give you a history of lymphadenopathy associated, they are talking about non-Hodgkin's lymphoma, or they can just give you an image with multiple cysts, or they can give you a history of HIV or Sjogren's syndrome and what malignancy it can lead to. This is all higher age, but you need to know it can lead to non-Hodgkin's lymphoma. Okay. Which statement is true about acute interstitial pneumonia? It presents subacutely with waxing and waning course. No, not correct, because we know that it has got a very poor prognosis. It presents very acutely and it rapidly deteriorates. Okay, there is no waxing and waning noted in AIP, so obviously this is not the answer. What about it is strongly linked with smoking? No, in smoking we know that either it is respiratory bronchiolitis or either it is a desquamative interstitial pneumonia or the DSIP pattern. Okay, so this is also not the answer. What about HRCT always shows honeycombing? See, I told you that honeycombing is something which is present only in the chronic state. Okay, so if something which is present very acutely, honeycombing will not be seen. So the answer over here is, even if you have not read, even if you don't know the epidemiology of AIP, you can just, by ruling out the other options, you can reach to the correct answer, which is it occurs in middle-aged, previously healthy individuals. Okay, and it will present very acutely with a very poor prognosis. What is it also called as? It is called as Hammond-Rich syndrome. Okay. Which of the following is true about the prognosis? Both RB and ILD, both RB, ILD. Okay. Okay. The last one. Okay. So the last one, let's move towards our last MCQ. Which of the following is true about prognosis? Both RB, ILD and DIP have poor prognosis similar to UIP. So this is completely wrong. We know that it is smoking related. Cessation of smoking, it is usually reversible. UIP has a very poor prognosis. What about DIP has a better prognosis than RBILD? No, I said that RBILD is usually present earlier. It is present in the upper lobes with these nodules and it has got a better prognosis than DIP. So this is wrong. DIP is unresponsive to steroids, option number D. No, I say that it is reversible and it has got a good prognosis also. What about, obviously the DIP has got a relatively poor prognosis as compared to RBILD. And what about option C? RBILD often improves with smoking cessation. So that is our answer. Yes, if you stop smoking, then these nodules will also disappear on your follow-up imaging. Okay, so I hope this was helpful. This was all about interstitial lung diseases. So guys, I have covered each and every point which is commonly tested on the radiology residency examinations and also on the competitive examinations. If you have found this useful, please comment down and do subscribe to my channel. I will try to make some important topics in such small short review series, and if you want a specific topic to be covered, please comment down and I will try to make that topic. Thank you so much. This is Dr. Natisha Arora.